Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page, @FabulousPharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke with Prof.Jack Lambert. Jack is a consultant in infectious diseases in the Mater Hospital in Dublin, and he is also a clinical professor in UCD School of Medicine. We discussed long COVID and how difficult it is for patients to access care. We discussed the reasoning behind the closure of his public long COVID clinic. We also discussed his extensive research in Lyme's disease, Hep C, and HIV. You will not want to miss this podcast from this entertaining and outspoken doctor. To support the Laura Dowling Experience, please check out sponsors in my podcast notes below. Enjoy the show. Jack, welcome to the podcast. I'm delighted to have you here. Thank you so much for joining me. Just by way of introduction, you are a distinguished consultant in infectious diseases at the Mater and a clinical professor at UCD School of Medicine. You have also worked extensively on HIV and Hepatitis C. Your impressive lengthy CV includes your work as the director of the STI Clinic and the director of the National Isolation Unit for Highly Infectious Diseases. More recently, you have become the voice for long COVID patients, and you also deal with Lyme's disease as well. So, you know, that's only skimming the surface. So what can we just go back to the start on how you got into medicine, what your childhood was like, what brought you to it, and then ultimately into infectious diseases?
Well, I guess I was always programmed from day one to become a doctor. It's just always something I was interested in. I come from west of Glasgow, so none of my, and come from, I guess you would say, a fairly deprived, kind of background, living in the tenements, living in the slums. And none of my family went to university, but my parents, who had to leave school early, just to support the family to go to work, in Scotland in the post-World War II, encouraged all of my brothers and myself to get an education. And so I did. So that was really kind of the beginning. I was always interested in medicine from the very beginning, probably the first in my family to go to university. And I've never kind of, gone in any other direction except towards medicine. My original interest really was in infectious tropical medicine. My parents immigrated to America from west of Scotland because of the unemployment situation, similar to a lot of Irish did. And I got my education in America, studied in America. HIV AIDS came along during the time that I was training in New York. So that really became the focus of infectious diseases. I worked a lot in pediatric AIDS, mother-to-child transmission of HIV, developed projects actually from my base in America, kind of around the world for HIV and AIDS. And then finally, decided for lots of reasons, including family reasons, to move back from America to the UK. I returned to the UK in 1999, reestablished myself in HIV and AIDS. Looked for a job, and the best job that I really could find similar to the job that I had in America was in Dublin at Mater Hospital in UCD. So I arrived here in 2005, took on the work of HIV, sexual health. I had an interest in hepatitis C because it was kind of a new disease at that time. Did a lot of work, research, and implementation of hepatitis C treatment in Ireland. And have taken a lead on that. Developed research projects on that, was funded through the European Union for studies on hepatitis C. And then it just happened that there was a lot of patients with Lyme disease that I started seeing because nobody else was seeing them.
And why was no one else seeing them?
Well, for some reason, Lyme is different than most other infectious diseases. It's such a political disease. People have strong opinions. And if you talk to patients with Lyme, if you mention to a doctor they have Lyme disease, they get this, the doctor rolls their eyes and kind of shrugs them off and puts them into the crazy basket, So Lyme is something I knew about because I worked in America, I trained in America, I was in upstate New York, I was in Baltimore for a number of years. So I saw lots of Lyme disease cases. And when patients came to see me in Ireland and I realized that nobody else was seeing them, I kind of took more of an interest, just because, I guess I've always been interested in going into areas where other people haven't, rather than kind of jumping on the bandwagon, kind of joining other people when things have already been discovered. So Lyme to me seemed like a kind of what I call kind of a new opportunity to better understand the disease, because I always say if patients are sick and you can't figure it out, you have to believe the patient.
Yeah.
And don't say there's nothing wrong with you, this is all psychiatric, all your tests are normal. Well, if all your tests are normal, I always say maybe you haven't done the right test, or maybe we haven't developed the right test to make the appropriate diagnosis. So I kind of took on Lyme disease as an interest, and I probably worked on that for the last 10 years, clinically taking care of patients in Ireland and elsewhere within the UK. I get referrals in from throughout the European Union to see people with this disease. Yeah, so I see people from all over, because it's if you look at the medical literature and you look at people's opinion, Lyme is easy to diagnose, easy to treat, and people are 100% cured with the treatment. But the reality is that's not the case. So tick-borne infections, Lyme disease is spread by a tick, are probably much more common than we're aware of. We don't keep statistics in Ireland, so people say, oh, there's only 10, 20 cases reported, but that's because it's not reported. There's probably thousands of cases, and people are probably misdiagnosed with other alternative diagnosis rather than Lyme disease. But anyway, I took an interest in Lyme, did my homework on the subject. There's a lot of medical literature dating back to the 70s on Lyme disease that most of my colleagues are not aware of, or they've chosen not to research.
Yeah, because I did a little bit of research before you came, and there would be people that would disagree with your stance on Lyme's being a chronic illness. People that think that if you give the antibiotics, it should be cleared within a couple of weeks.
Yeah.
But this is not something that you've found.
Well, it's not just a matter of me finding. I mean, look at there's a Center for Lyme Research at Johns Hopkins University. I used to work at Johns Hopkins. Johns Hopkins is reputed to be a good institution, maybe second best in the world. Harvard and Hopkins always compete for who's number one. So some years it's Hopkins, some years it's Harvard. But nonetheless, there's a Center for Research there, and they see people who've been treated for Lyme who are still sick despite being treated. And they call it PTLDS, post-treatment Lyme disease syndrome. And when you do scans, and they have all these symptoms, similar to long COVID, and when you do brain scans on these people, there's abnormalities.
Okay.
So you have to do the right kind of brain scans. You have to do PET scans. Not CTs, not MRI scans, but there are hypoperfusion defects, lack of blood flow to certain parts of the brain, which are exactly the parts of the brain that their clinical findings are coming from. So there's something there.
Right.
So I don't care if people say, so PTLDS, post-treatment Lyme disease syndrome, that doesn't mean it's post-infectious. It could be post-infectious. It should be partially infected. It could be partially treated. It could be post-infectious. It could be persistent infection. We don't know. We don't have good PCR tests for Lyme. We have antibody tests.
Yeah.
But antibody tests are imperfect. And most of my colleagues say, oh, the antibody test is 100% for Lyme. Well, it's not. It's less than 50%. And if you do a PubMed search, the data's there. But why did the guidelines say, that the test is 100%? So ticks, my colleagues say, oh, you never saw a tick. Well, the tick is the size of a sesame seed. How many people would notice a insect on their body if it was the size of a sesame seed? Say it was behind the back of your neck. I don't check myself with mirrors daily when I go out in the woods to see if there's sesame size ticks on my body. So 15% of people remember a tick bite. That's what the medical literature says. Less than 50% of people get the bullseye rash. People may present a few weeks later or a few months later just with flu-like illness, non-specific findings,
Yeah.
But so I think there's a lot more tick-borne infections, Lyme disease out there than we're aware of. And people also say that 2 weeks of antibiotics and you're cured. But I see so many people that get 2 weeks of antibiotics get better. And then you stop the antibiotics, they get worse.
Okay.
Well, if it was a cellulitis, what would you do? If it was a skin infection, you'd say, oh, 2 weeks wasn't long enough, they relapsed. But with Lyme disease, we say, oh, the infection's cured. You can't get any more antibiotics. You got your 2 weeks.
Yeah.
Well, that's not true for any other infectious disease. So I treat patients, not guidelines. And there's lots of literature to show that if you treat people for longer, they get better.
With the antibiotics?
With the antibiotics, yes, they do get better. But if the infection's been in your system for years and years, it's not just the infection, it's this damage it's done to the immune system, it's the inflammation. So the guidelines for the treatment of Lyme that's not diagnosed to years and years later are still the same, 2 weeks of antibiotics. Okay. But if you look at other infectious diseases, if you catch it early, it's a short course treatment. But if you catch it late, it's a longer course treatment. For Lyme disease, there's no differentiation, about that.
And when you reference their PubMed studies, so I think that sometimes you can go onto PubMed and you can find the answer that you want for anything. Right. How reliable are the PubMed studies that you're referring to?
Well, the thing is that if you look at, let's use arthritis. One of the complications of Lyme is arthritis. Well, there's a condition called late Lyme arthritis. It doesn't show up till months after a tick bite, maybe even a year later. And the guidelines on treatment come out of Yale. The people who discovered Lyme came from Yale University to Old Lyme, Connecticut, to do an investigation on kids who had this mystery rheumatoid arthritis, juvenile rheumatoid arthritis. That was the beginning of Lyme disease, 1975, the investigation done by the patients, by the investigators from Yale. Well, they've published on late Lyme arthritis and late Lyme arthritis requiring months and months and months of antibiotics. Well, how come that's been lost in the medical literature? And patients and doctors now say you only need 2 weeks of antibiotics, and they send them on their way and they don't bring them back. Well, I've done my homework. I've checked the medical literature. In some cases, people need longer course antibiotics. And when I see them and I follow them up and I bring them back for visits, they improve on longer term antibiotics. Yeah. And if you stop the antibiotics too soon, they get worse again. And I'm just a very simple person. I treat patients, not guidelines. And I think we should all be doing that. We should be treating patients. There's guidelines are guidelines. Well,
I think that's why you came on my radar initially, because when I told a couple of people that you were coming on, they said, oh, controversial, Jack. And I think that relates back to, I suppose, the talk that was going on during the COVID lockdowns, where you were suggesting that we should be lifting the restrictions and wearing more masks, but not actually shutting down and causing this economic problem that COVID did cause. So, but obviously you've done so much work with long COVID and you have seen a lot of long COVID patients, and your clinic in the matter was shut down, that wasn't given any funding. Was it just late last year?
Yeah, well, the thing is it was never funded. We were given an HRB grant back in May of 2020, and I used the money from that grant to support establishment of a clinic. And we went and applied to the HSC for funding, but our business plan seemed to be lost in space and never reviewed and never dealt with. And ultimately, we never received funding. Funding went elsewhere. And when we found out in March 2022 that funding had been given elsewhere, my CEO basically said, Jack, you can't run a clinic on no money, because the HRB Health Resource Board funding had run out 6 months before. So he kindly allowed me to continue the clinic for another 9 months as we submitted a new business case. But the business case just went on deaf ears, and it's been a bit of a it's been a bit of embarrassment, I would say, to the HSE, the way that they have not dealt with us submitting a business plan for ongoing funding, because we were the original center. Yes. We saw all the original patients, if you remember back in March 2020, all of the patients who were came back from travels to northern Italy from the ski, they were brought to the mater. A lot of our staff became infected from being the first center to manage patients. We established a long COVID clinic, and being the first center, and over a period of years, we saw over 1,500 patients. A lot of them healthcare workers, and a lot of patients were referred in from all over the country, especially healthcare workers, who had been there. So we were quite dumbfounded when we found we weren't funded. We approached the HSE with a new business plan, but the business plan went nowhere. And I started, rather than emailing them and contacting them, I started doing some Twitter just to see if we could get any leverage. I started approaching the TDs, the ministers, everybody to say, what's going on here. But it just became, like I said, a bit of an embarrassment. The TDs would put in a parliamentary question asking the minister, what our business plan was submitted in July, in October, there's a question to the minister, what's the status of the Matter's business plan? Mm-hmm. So what do? They contact the Matter, department to say, what's the status of the business plan? The Matter responds, we haven't heard back from the HSC on the status of the business plan. So the response from Donnelly and his group is that the Matter hasn't heard back.
And do you think that, so you were the pioneer for long COVID in the Matter and all the data was collected there initially, as you say yourself. Do you think that quite possibly because you were outspoken against some of the policies that NPHET were trying to instill, do you think that may be why the clinic wasn't given the funding or why they're not listening to you?
Well, that's what some of the patients think. I would hope, I would hope that people within the HSE and the minister wouldn't sink to that level, mm-hmm. to be perfectly honest, because we're, you go into medicine to take care of patients and everybody has personal disagreements as far as that goes. But stepping back, being controversial, I mean, when you listen to comments from NPHET saying that children are not a source of infection, kids don't transmit COVID, and you see all the COVID in the school, and you see all the children bringing COVID back to the households and infecting vulnerable people, and you have repeatedly members of NPHET standing up saying that that children are not a source of spread of COVID. I mean, I disagreed with that.
Yeah,
it's wrong. It's just inaccurate information. When you hear the government stand up and on announcements saying, get your COVID vaccine, protect yourself, protect others. Well, these are therapeutic vaccines. They don't protect you from catching infection. They protect you from severe disease. Mm-hmm. But the information given by the government to people is that the vaccines are going to prevent you from catching COVID. Masks are what prevent you from catching COVID. Now, masks are not 100%, but vaccines don't prevent you from catching COVID, these therapeutic vaccines. So I wouldn't say that I'm controversial. I would just say that I guess I would expect the government to hire people with the knowledge to be able to disseminate accurate information to the Irish population.
And you don't think that they've done that?
They haven't done that in some situations. Okay. And that's when I've spoken up.
Yeah.
And even when they talk now with long COVID, talking about having the really robust plan for, to an interim plan to establish centers to manage post-acute COVID, and then et cetera, we've all known since early 2021 that the residual damage from long COVID is the brain.
Yes. And
the HSE came out with an interim plan that I first saw in March 2022. That's the first I ever saw their interim plan. And their interim plan funded 8 pulmonary centers, 6 infectious disease centers, and 1 neurological center as a subspecialty clinic.
But it's not a pulmonary issue.
It's not a pulmonary issue. It's not an infectious disease issue. It's a neurological issue. So if I was going to put my money into supporting patients in Ireland, I would have, 8 neurological centers, not 1 subspecialty neurological center, because the problem is brain injury. Well, and I see patients going to the pulmonary centers with brain fog and with tinnitus, and they're going to see these pulmonary specialists who have been funded to run long COVID clinics, and the patients are told, exercise more, which makes you crash when you're exhausted. Wrong recommendation. Patients with brain fog are sent for pulmonary function tests. why is getting a pulmonary function test going to help your brain fog? It doesn't. And then issues of tinnitus. I mean, one of the patients was told, go Google tinnitus on YouTube and learn about tinnitus, because they had no idea. So I just think that an awful lot of the strategy that's put together for the long COVID plan in Ireland is outdated. And the government keeps on defending, saying, this is an interim plan. When new data comes along, we'll take it on board.
And are there other countries that are more specific for neurological plans, etc., or are we following everyone else's?
Well, I think we followed the UK. I think the UK was one of the first to come up with a long COVID plan. They come up with a plan on 2021 and really focused on cardiac and pulmonary, because in the first wave we thought that was going to be the complications. We actually did. I think, as far as I can see, Ireland just took a carbon copy of that, put it together. 18 months later, they implemented it. By then, the science had changed. Mm-hmm. So it's a bit too little too late. And yes, other centers in France have a really robust plan, really focusing on neurorehabilitation. And actually just this last week, Scientific America, the Scientific American, the journal, came out with a huge publication of, now we have the answer. Now we have, guidance we can give to, clinicians on how to manage long COVID, and it's focused on the brain.
Okay.
And it's work out of UCLA. Well, this is not new. And we keep on getting this mantra coming from the HSE, we have a robust multidisciplinary plan to manage patients in Ireland. When new information comes along, we'll take it on board. Well, wait a second. The new information's been available for a year and a half. They keep on defending the indefensible. They got it wrong. They should change direction. Now, the business plan that we put together for the matter, we submitted one in July 2021, and we submitted another one in July 2022. It's not asking for infectious disease specialists. I'm an infectious disease specialist. And I think the plans that have been developed to date have actually been quite self-serving for the consultants that put them together. They got specialists for their hospital that are doing things other than COVID. That money's been ring-fenced for COVID, not for doing sleep apnea clinics. Not for doing HIV clinics, it's for long COVID. So most of the services have not been used to that. But the business plan that we put together was for neurology support, a neurorehabilitation specialist, psychology, psychiatry support, neurorehabilitation. I see long COVID, the damage from long COVID is very similar to, say you got a brain injury, say you got a concussion. Mm-hmm. Afterwards you have to retrain your brain to work. People who have brain injuries, they often have, sleep disturbances. They have problems with memory. They have emotional lability. They have all sorts of problems. Mm-hmm. They don't have a psychiatric disorder. They had concussion. They had brain trauma. People with long COVID have a lot of, and the data that we've actually published from, the HRB grant, we've got 18 publications from the matter on COVID, long COVID. Now, every other center in the country combined have 2 or 3 publications total. We've done the work, and the data really shows that the people have ongoing neurological issues a year after their COVID. People have ongoing emotional issues that are triggered by brain inflammation. They're not anxious. They're not depressed.
What kind of percentage of people suffer from long COVID then, post-infection? Do we even have a statistic there?
Well, the data that we have from the matter that, like I said, this is from the HRB grant. We actually have published this, is about 30% of people still have significant, of the patients that we followed, we did questionnaires on them, and about 30% of them still have significant, physical abnormalities at 1 year. And some people say, other studies have said 1 in 10, but as a rule, there's, I would say, about a third of people still are suffering from long COVID. Some of them totally floored, unable to get out of bed, but some of them what I call the walking wounded, people who are going to work. I saw a patient today, and she's a nurse, and she used to work on the wards, and now she's been given a job where she is working from home doing screening, because that's all she can do. That's all she can do. 2 years down from getting COVID, she has long COVID. If she pushes too far, she gets stressed, she gets anxious. She was never an anxious person years before. She's approaching 60. She's lived 58 years of her life not being anxious. All of a sudden, she's got anxious. And now she's been kind of told, you have an anxiety disorder. Now she's been told, you need to go back to work again without any kind of intervention and support.
There's no clear pathway for GPs to refer people on either with long COVID, is there? They tend to be prescribing them with, nerve blockers, painkillers.
Yeah, exactly. And that's the challenge. There really needs to be guidance. And part of the business plan we put into the matter was actually to hire a GP to actually put together educational modules for GPs. There is guidance that's come out, from British Medical Journal just did a review of the symptoms of long COVID, and how to manage it. How do you manage sleep disturbances? Well, I see so many times people being put on Zopiclone, put on Dalmane. These are addicting sleeping pills, okay? Mm-hmm. But if you go to your GP, you get put on Dalmane or Zopiclone, and it zops you. And you sleep for the night, but then you're hungover for a week, and some of these nerve killers as well, they do block the nerve pain, but then they affect the CNS. They make your brain fog worse, There is guidance out there. One of the drugs that I use for sleep disturbances is melatonin. And melatonin, I say, is actually used for head injuries. It's used for a number of different, psychological conditions, and including children with behavioral disorders. It's not like a sleeping pill. I call it more like a sleep hormone. It regulates your sleep pattern. Do
you think it should be available off prescription here in Ireland?
But it should be available. Yeah. That's my point. My point is patients are having to pay out of pocket, and the HSE should really catch on. The British Medical Journal have guidelines that published in June 20, and they talk about sleep disorders, and they mention using melatonin.
Yeah.
It's, so this is not new. This is almost a year old. So there's stuff out there. Why am I looking at the medical literature and coming up with these guidelines? And then here the GPs in Ireland have no guidance, and then the HSC is not supporting the use of melatonin, which is a much better option, I think. And it's used for head injuries. It's used for,
and it's so expensive because it's unlicensed here as well. But it's actually there's one that's available, but just patients are paying so much money for it, and if they can't afford it, if they're on the medical card, they have to go on the hardship scheme. It's a massive palaver.
It is absolutely ridiculous. I have a 19-year-old son who uses gummy melatonin because 19-year-old boys can't swallow tablets, unfortunately. So when I go off to America, I go to CVS and I pick up gummy melatonin 10 milligrams over the counter, 120 for $9.99.
Yeah.
When I was at a meeting in Paris just about a month ago with one of my projects, and I stopped in Charles de Gaulle, the pharmacy there, and you can get melatonin over the counter there for, 120 of them for 33 euros. We need to kind of come up with, we need to support patients. So melatonin is something that I think that we should be more supportive of using, because sleep disturbances it's a much safer option than prescribing these addicting sedatives,
What about low dose naltrexone?
Yeah. So LDN is a drug that's been used actually for long term. I used it back in the 80s for HIV and AIDS, and there's placebo-controlled trials that it can be used because it has some kind of anti-inflammatory effect, and it has some kind of immune modulation effect. And if you look at the complications of long COVID, it's inflammation of the brain and the nerves coming out of the brain. There's some kind of immune defect as well. I think COVID hits the lymphocytes, the white cells of the body. So people have, and lymphocytes kind of regulate your immune system. So it has immune modulating effects. And back in the days when it was used for HIV and AIDS, it helped patients, because, and then subsequently rheumatologists have done studies with using LDN for atypical rheumatoid arthritis with improvements of joint pain. Neurologists have used off license for, and saw improvements in brain imaging and in clinical manifestations. Gastroenterologists use it as an immune modulator to spare some of the, immunomodulators they use for inflammatory bowel disease. So I started using it for, like I said, for chronic Lyme patients based on my experience before. And when long COVID came along, some of the patients I was taking care of at the Mater just weren't turning the corner, and a lot of brain symptoms, joint symptoms, insomnia symptoms, mood symptoms, and we actually just offered them, prescription LDN based on my experience with the chronic Lyme patients. And we did a questionnaire before and after starting therapy. We actually published this. It's just a pilot, but it wasn't a clinical trial. It was just kind of an observational study of prescribing it for the patients. But within 2 months of starting LDN, these were otherwise previously healthy, mostly young adults, mostly healthcare workers. Within 2 months of starting the LDN, they'd been sick for 333 days. Their pain, their brain fog, their concentration, their mood, their joint pain all over, as I mentioned, their sleep disturbances, all improved within a couple of months based on the questionnaire. So it's a safe option. Interestingly, if you're in Ireland, in some areas you can get LDN covered, and if you're in other areas, you can't get it covered.
So you're talking to a pharmacist who knows exactly. It's unreal the way a colleague of mine can get that approved for someone on their scheme, and then me up in Dublin can't for some reason. Yeah, it's just wild the differences even in the different areas.
But it just shows you. I mean, healthcare systems are supposed to be efficient. Healthcare systems are supposed to work for the whole of Ireland. It seems like we work in little fiefdoms. We're in little fiefdoms, and it has to do, whether this person wants to, or this person wants to, or this person tries, or this person doesn't try. But if LDN is benefiting patients, I can't think of many other therapeutics are proven, or at least have the same potential as LDN. Studies are going on internationally now with LDN, but those results won't be available for years. No. I think it's a no-brainer that we should have it available. It's one of those old
drugs that's been around for years. It's not worth much money to the company that makes it. Therefore, licensing in Ireland is not worth their time. And it makes it just really expensive, and it makes it prohibitive for you to prescribe as well when it comes down to it, because the very fact that it's unlicensed, then it needs to be made up because they don't supply it in a formulation. It's just it's mind-boggling how difficult it is to get help when you are a patient like that. Is there a massive backlog of patients that want to go and see you, or? Well, obviously you can't see anyone now publicly. Is that right?
Yeah, exactly. We gave the HSE every opportunity to review the business plan, waiting for July. My communications I was persistent communication to the minister, but the response has always been just totally ignoring the issue. So we had to close down the clinic. We had no choice. You can't run a clinic on no money and have a clinic across the road fully funded with a specialist who's not seen patients. Is
that what's happening?
Exactly. I would say, I just got a recent communication from the minister basically saying the Mater has a post-acute pulmonary clinic, and the long COVID clinic was given to Vincent's Hospital. Well, why was the long COVID clinic given to Vincent's Hospital? And the answer was they decided to give long COVID clinics to hospital groups.
Okay.
So if you've got 1 million cancers up in Donegal, you don't do a cancer center up there. You give it to the hospital group in Drogheda. It makes no sense to establish centers based on hospital groups. You should base it on disease severity, hospitals that have the specialty interests, and also inner city Dublin. North Dublin inner city is a deprived area with a high incidence of morbidity, including long COVID. Yeah. But the decision was made that the clinic was given to Vincent's. So as of December, I had to terminate my clinic, and all the patients I've seen were referred on to St. Vincent's for follow-up care. But many of them won't go there. Many of the North Dublin patients won't go there. And then half the patients I saw were not from the North Dublin catchment area anyway. They were from all over the country, because I was seeing, ambulance drivers who were referred in. I was seeing, care assistants, nurses, doctors, Red Cross drivers and stuff who were infected on the job. Yeah. Referred in to see me at the Mater Public over the last year. And then there's nowhere for them to go because they don't live in the North Dublin catchment area. A lot of the staff at the Mater Hospital I was seeing, they don't live in the North Dublin area. They live out in Meath, Westmeath or Kilkenny or something like that. So they can't be referred on to Vincent's because they'll only see patients from the North Dublin catchment area. So it's a bit of what a scandal.
It's a bit of a head melt. And then that brings on into...
It's a scandal. It's an absolute scandal. And it's not fair for patients to have this kind of, I think it's cruel. It's absolutely cruel that, and then the response from the government is, we have a robust plan. We're doing everything right. We have a multidisciplinary model that is world class. Ask the patients, ask the GPs. There is no guidance.
And is it a case of, if you have enough money, you can get looked after? Is it this two-tier healthcare system that is getting worse and worse in Ireland? Are you seeing that?
Absolutely. And like I said, I still will see patients privately because that's the only option. Before, when patients were referred in, I had the option of seeing them privately, but I had them all funneled into the public clinic, because but unfortunately at the present time, the only way I can see patients is privately. And so I do get referrals in, but those who can't afford it are in trouble. But even some of the private patients I'm seeing is that, some of them can't afford the supplements. Some of them can't afford the melatonin. Some of them can't afford the LDN. I think we actually have to, kind of take a look at, what's going on. I saw a patient today. I'm seeing patients who are seen at some of the private, centers for long COVID, and they get test after test after test after test done. They get referred to specialist after specialist after specialist after a specialist. Oh, your intestines hurt. So you get a colonoscopy done. Your heart hurts. Go see a cardiologist. Oh, you have air hunger. Go see a pulmonary specialist. On and on. They're being referred on to many, many private, specialists. Okay. And they're getting test after test after test after test. At the end of it all your tests are normal. And then they've been discharged from clinic without any attempts to improve their symptomatology. So even those who have money, they're going through a lot of referrals, but at the end of it, there's not a lot being done to support them.
It is quite scandalous when you say it like that, isn't it?
Well, that's my observation.
Yeah.
And like I said, I have the records, I have the charts, and I record them. I mean, recent nurse from Tipperary that come up to see me, out of work for 2 years, heart rate gone up to 170, dropping down to 35, seen by a private cardiologist. She paid out of pocket. All your tests are normal. At the end of it, you're just anxious.
Okay.
Actually, she was told in discharge, after praying for private consultation, no intervention at all. Well, the science is that the vagus nerve and the sympathetic parasympathetic nervous system are overstimulated as a function of long COVID, and that is the thing that's triggering.
Is that due to inflammation that it's caused?
It's due to inflammation, and it's causing tachycardias, heart going too fast, heart going too slow, dysregulation. People are getting these hot flushes, too hot, too cold, blood pressure is up and down. It's all coming from the brain. But people are getting cardiac ablations. People are getting put on beta blockers, which are going to. Your heart's already going down to 35. You don't need a beta blocker to, it's going to block it from going up to 170. But, there's a huge amount of resources are being, I think, misdirected.
Okay.
At the present time, and the national plan for long COVID in Ireland is missing the target, and there doesn't seem to be a willingness from those who are in charge of putting this together, this plan, to keep up with the science and change the plan. I mean, this is what you do in medicine. You change direction based on new knowledge. You don't defend your mistakes. And it's okay to change
direction and say, okay, we didn't know that then, but we know it now, so let's move forward, as opposed to continuing, railroading through a plan that may have been okay 18 months ago, but isn't now.
Absolutely, and that's exactly my point.
Okay. Can I talk to you a little bit about your work with HIV and AIDS?
Mhm.
Because you did a lot with pediatrics. You mentioned it at the start, and I find that very interesting. But that was at the very start of the pandemic. Epidemic. Is that what
Yeah.
they call it? Is an AIDS epidemic? They called
AIDS,
it.
yeah, it was an epidemic. Yeah.
Yes. So how did you get into that? And you did visit? Did you visit sub-Saharan Africa as well?
Yeah.
During that time? I find that
Sure.
interesting. And are you still doing work in that field now, or are you mainly focusing on what we've just spoken about with Lymes and COVID?
Well, like I said, I was in 1981 when I graduated in New York. The first cases of HIV were occurring, and when I was an intern and a resident, we started seeing a few patients with this funny immunodeficiency, and then we started seeing children with this funny immunodeficiency, and then next thing you know, some of the first infected women who were drug users at that time got HIV and AIDS, and some of them got pregnant, and they were delivering babies who were born with HIV. So I was there in my training during that time period, and I nobody was interested in pediatric AIDS. Nobody was interested in pregnant women with HIV and AIDS. So I kind of took that on because people were afraid.
Okay.
I don't want to deliver a woman who's HIV positive. I might catch HIV myself.
Okay.
So it's kind of interesting. There was huge fear and a lot of stigma, and then a lot of people just didn't want to get involved because it was gay men who got HIV, it was drug users who got HIV. It was the whole stigma. So I kind of took an interest in that, going back to the 80s, became involved in that. Had NIH grants involved in that. Did some of the sentinel work on mother-to-child transmission of HIV. Was involved in the pediatric AIDS clinical trials group in America. So I was, which was a national organization. So I was actually principal investigator of the pediatric AIDS clinical trials group at Johns Hopkins when I was working there. Did probably 40 studies in HIV and AIDS, and then trained lots of people internationally who come over to visit Baltimore as part of a program called Fogarty International Training. So we trained people from Brazil, India, Africa, the Caribbean, Thailand. So I developed a network of people that I trained over the years, and then they invited me back to go visit their country. So I went to Brazil, worked on projects down there. I actually had an NIH, National Institutes of grant on pediatric AIDS down there, which was funded. I worked on projects in India. I got asked to kind of adopt an AIDS orphanage in India to help provide HIV medicines for these kids. So I get involved in that. So I was able to travel. And then finally, I got invited to South Africa and actually got pharma money from GlaxoSmithKline actually to run projects in South Africa. So I actually did projects and educational projects on mother-to-child transmission of HIV, projects on pediatric AIDS in South Africa. Went out there and worked with a program called CHIVA, the Children's HIV Association in the UK. So we go out for a week and we go around the country as part of a project to rural communities to train the hospitals on how to manage pregnant women with HIV. If you give a pregnant woman HIV medicines, the baby doesn't become infected. It's that simple. So that was. So, and if they have an undetectable viral load at delivery, being on the HIV medicines, none of the babies became infected. And that was kind of my original work that I'd done back in 1999. So that was published in New England Journal. So that was kind of sentinel, that if you have an undetectable viral load in a pregnant woman at delivery, none of the babies become infected. So the rollout then is to put all pregnant women on HIV treatment, then none of the babies become infected. So I worked in projects between kind of 2008, and I quit going out to South Africa probably right before lockdown COVID, 2018-19. Worked in Durban, South Africa. Worked in the Eastern Cape, which is the poorest part of South Africa. I mean, the rich and the poor disparity there is incredible. Kids starving, kids with marasmus, kwashiorkor, malnutrition, huge inconsistencies between rich and poor, huge corruption in the healthcare system there as well. But it was really a great opportunity to go out and work. We trained a lot of people, brought some of the UCD students out there. One of my nurses I actually brought to a project in Cape Town, and there was a AIDS orphanage there in Kailicha, which is the big slum around Cape Town, South Africa, and we called Bafo Children's Home. We did a training program out there, hospice training program with a hospice in Raheny. So I've been involved in lots of HIV projects over the year, with a special focus on mother-to-child, child and pediatric AIDS.
Sorry, when you say an AIDS orphanage, is this children that have AIDS and they're going to die?
Well, the thing is that they die if they don't get treatment.
And are they not getting treatment out there?
Well, the treatment back when I was out there originally, like I said, the AIDS orphanage in India, there was no treatment, so kids were dying. But I was able to kind of go to one of the rich, Indians who ran one of the big pharmaceutical companies called Cipla Pharmaceutical Company, and I ran some training projects for him on mother-to-child transmission. He actually donated money for the HIV drugs for the children. Okay. So their kids are living now, and in South Africa, that they do have free drug available if you identify the children and treat the children. But the trouble is there's so much chaos in these places. There's so many orphans around. There's so much, many kids falling through the cracks. So it was kind of a great opportunity back in those early days to kind of get the ball rolling, to get kids started on treatment, to train doctors to be comfortable prescribing drugs for children, because everybody's comfortable giving pills to adults, but people aren't comfortable calculating doses for children, and all the special issues that arise with children. So it was absolutely exciting to kind of be a part of the solution, working on South Africa, working, like I said, I worked in Brazil, I worked in projects in the Caribbean, worked in India on these projects, mostly focused on, educating people on how to prevent HIV by treating the pregnant women, and then for children who are diagnosed, how to get them on treatment early. Because if you get them on treatment early, they can actually live a normal life.
But it's lifelong treatment, and it has to be taken every day.
It has to be taken every day for the rest of their life.
That's the issue. If there's the chaos that you're talking about, isn't that right?
Absolutely. And children still die because of the chaos, because they fall through the cracks, they quit taking the medicines, a parent dies. If you go to most of these third world countries, it's the grandparents are taking care of these AIDS orphans because the parents have died, or their parents have just absconded and taken off. Okay.
And what's it like in those countries now? Because it's a very different situation here in Ireland. Mm. Is there anyone that gets AIDS now in Ireland, or are they more or less caught on time and put on their antiretrovirals?
Yeah. Well, most people get started on treatment quite quickly now. And if you look, Ireland does well because the drug is free. Most people are diagnosed, but there's still people who are in denial. We still see a few cases of people showing up with full-blown AIDS, just like early on in the HIV epidemic. People who don't suspect they could have HIV, or people who are, because of the stigma still, that are not unwilling to go in for testing. So that still happens. But most people in Ireland, I would say, are diagnosed. Most people are put on treatment. Most people have an undetectable viral load, and very few people die of HIV and AIDS anymore in Ireland. Same thing with children. Most pregnant. I run a clinic at the maternity hospital at Rotunda, an infections and pregnancy clinic. So we see the HIV positive women, put them on treatment, make sure that they have an undetectable viral load. The babies don't become infected. So it's really a success story. And then finally, for there's this project called PrEP, which is HIV PrEP. So for people who are not willing to, or to use protection.
By protection, you mean condoms when they're having sex?
Condoms when they're having sex, this and that. I mean, HIV is transmitted by penetrative sex, either, heterosexually or MSM. They did studies a number of years ago in London, where at Dean Street Clinic, where they actually brought gay men in, tested them the same day, and if they found them positive, they started them in treatment right away. And this was kind of, and rather than them being out there with an HIV diagnosis, and you can't change their sexual behaviors, but if you actually get them on treatment quickly, you'll prevent them from getting infections. So there's lots of strategies for early diagnosis, and then there's studies that have been done in people who are negative if they take the HIV drugs every day or take the HIV drugs intermittently when they're planning on having sex, it reduces the incidence of HIV. So studies have shown that if you test people quickly and get them started in treatment, or get people who are HIV negative and keep them on PrEP, there's less new HIV infections. So those strategies were initiated in the UK and in other studies worldwide. And Ireland now has a very robust program, I think, to early diagnose people who are HIV positive. There's access to HIV testing for newly diagnosed people and getting them on treatment quickly. And there's PrEP programs that are funded by the government for people who want to access such services. So there are some good services in Ireland for that population.
Do you see, though, because PrEP is available, which is great because people do not transmit HIV, but is there then the knock-on effect that people are still then having unprotected sex, and there's other infectious diseases then that are being transmitted, such as, gonorrhea, syphilis? Is there an increase in them since PrEP became available?
Absolutely. I think there is. I think that's the overall thing. If you don't use a condom, if people say, I'm taking PrEP, I don't need a condom, but PrEP works for HIV. PrEP doesn't work for hepatitis. It doesn't work for syphilis, gonorrhea, chlamydia, all the other STIs. So yes, absolutely. There's an increase. The other thing, though, is that people aren't aware of is that all these other infections can be transmitted not just by penetrative sex, they can be transmitted by oral sex. Mm-hmm. And so many people are not aware that all these STIs, except for HIV, can be transmitted by oral sex. So this is just it's an educational message, you know, but nobody's going to use a condom to have oral sex.
Yeah, no, they're not. No. Sure, people don't really like using condoms for penetrative sex either. Yes, so absolutely. Why are they going to do it for oral? But are you ever concerned of another, say, HIV type illness coming about because of mutations, etc., because people are having sex, because PrEP is keeping it at bay? Is there ever the worry there that something could morph into something like HIV again? Or
I don't think so. I don't really think so. I just think that, I mean, there's always that theoretical possibility. I mean, where did HIV come from? HIV was probably a mutant virus that came from animals to humans, zoonotic infections, just like Ebola is an infection that goes from animals to humans. So zoonotic infections are common, and probably the HIV mutated in the 40s and 50s and 60s in Africa and then jumped from animals to humans. So there's always that possibility. We had a recent scare, when you think about it, monkeypox, right? Mm-hmm. We had monkeypox recently. Monkeypox, the good news is that the mutated monkeypox was not very virulent. It was a very docile virus, mm-hmm. But it could have been a more virulent virus. If you go to Africa, in Central Africa, the monkeypox strain there, one of the strains has a 10% mortality. So the monkeypox that mutated and ended up in the European Union and in America had a mortality of, 1 in 25,000. It was tiny numbers.
Did you see anyone die here from it?
No, I didn't see anybody. There was a few. There's reported cases of people dying for it, but it was 10% deaths in, Central Africa with the strain of the monkeypox that was there. The mutated virus that came out was less virulent. But answering your question, could we develop a new mutation, with HIV or some other sexually transmitted disease in the future? It's always a possibility. Look at COVID-19. COVID-19 is a mutated coronavirus.
Yeah.
Now it's mutating to become less virulent, but more contagious, mm-hmm. So it continues to circulate. So that's a good news story in the sense that it's a bad news story because it's affected our life, COVID-19. None of us have anticipated this 4 years ago, but, it was absolutely scary back in the early, months of COVID to see, hundreds of people in the hospital, including young people sick with COVID-19, with blood clots in the ICU on ventilators and this and that. The prediction was that it would mutate to become less virulent as it, circulated, and that's what's happened. But the consequence is it's less virulent, but more contagious, which means many more people are becoming infected, which, getting back to the long COVID situation, we're going to see more people with long COVID moving down the way.
And that was my next question. Is long COVID, it doesn't matter what mutation it is that people get infected with, they can still get long COVID. Is that right? There's no one particular strain that is more, I don't know, more responsible for long COVID, is there?
No, it doesn't seem to be. And it seems like there are some risk factors for higher chance of getting long COVID, but it doesn't seem, vaccines don't seem to prevent, and even a mild case of COVID can give you long COVID as opposed to being up in the ICU in a ventilator with COVID, So there is, it's hard to predict, that who's going to develop long COVID, but COVID is here, for a long time to come. It's not going to go away. I was hoping it would just kind of mutate and die out, because it wasn't usually the weak viruses die off. It's the run to the litter, kind of theory, but it hasn't died out. And it's going to continue for years and years and years. I mean, coronaviruses were first discovered actually in 1976. That was the first time it was isolated. It's been around probably for centuries, but they were only able to identify coronaviruses in 1976. And, it's actually a fascinating virus in the sense that if you look at the experience that people had with coronavirus, the common cold virus, people can get 3 infections in 1 year.
Yeah.
You don't make good antibody responses.
Yeah.
But the common cold virus never gave you brain fog and all the complications that,
this one's just
COVID-19
real nasty, isn't she?
It is. It's nasty in terms of the damage it's doing to the organs of the body, especially the brain.
Can I just ask you a little bit before we finish up about your work with Hep C? Because hepatitis C was something, again, that came about, was it the 90s that it really kind of started to spike in Ireland through drug use, really, yeah?
Yeah, it was. Primarily through drug use. And it was actually, if you go back to the textbooks, it used to be called, there was hepatitis A and there was hepatitis B, and everything else was non-A, non-B hepatitis. We didn't know. We knew it was probably a virus, but we didn't know what it was. So now we have hepatitis C, D, E, F, I think G. We've got a whole bunch of new viruses. But when they identified hepatitis C in the 90s as, one of the non-A, non-B hepatitis, the pharmaceutical companies were able to then, get interested in that as a target. And it's hepatitis B is a DNA virus. Once you've got it, you can't eradicate it because it's in the tissues. But hepatitis C is an RNA virus, so it doesn't get into the tissues and it doesn't integrate into your genome. So you can actually eradicate it potentially. And the pharmaceutical companies developed, new targets. And actually, when I came to Ireland, I said, that when looking at the numbers of cases of hepatitis C in Ireland, there was, 1 year, I think, back in 2005, 2006. I arrived in Ireland in 2005. There was like 1,200 new cases just in 1 year, mostly from injecting drug use of people not knowing that they were sharing needles. It was before they had needle exchange programs. But probably 20,000 cases, 30,000 cases in Ireland, new drugs coming along. So I when I came to Ireland, I said I would like to tackle the hepatitis C problem. I knew some of the people working in pharma. In fact, one of my buddies from America worked for Gilead, who is the major producer of the hepatitis C drugs, and he was working in North Carolina. So I was able to get him to bring, some research studies to the matter. So the first hepatitis C drug from Gilead was actually tested at the Mater Hospital, I think in 2008. It was, it was a phase, their first drug that they had for hepatitis C was a polymerase inhibitor. But that was the first drug that came along. And then Gilead brought a biotech company called Pharmasset for 20-some billion or something and took the whole portfolio. And they got lucky because all of the drugs from that portfolio became successful hepatitis C drugs. And, before the new drugs for hepatitis C became available, there was interferon, there was ribavirin, very toxic drugs that had maybe a 50% chance of curing you of hepatitis C with 6 months of treatment. Well, all of a sudden we had these new drugs. And like I said, we were part of the part of the studies to develop these drugs in Ireland. And here we are, years later with one tablet that you can take.
Remarkable, isn't it?
Take for 8 weeks.
Yeah.
With almost 100% cure. So we were a part of that program. I was able to apply for funding for a European Union grant called HepCare Europe. So we actually did some, pilot studies on taking the medicines out to the community. Because, everything is so hospital-based. You have to come to the hospital for your treatments. But most of the people with hepatitis C are vulnerable populations. They don't come to the hospital for all sorts of reasons. So we developed we were funded through the European Union studies in Dublin, in Bucharest, in London, and Seville, Spain. So we had a 3-year grant to kind of, roll out hepatitis C treatment into the community, educate the community, have mobile health units move into the community. So that was kind of exciting. And I think we've done a good job of in Ireland of trying to move into the community to target the population. Unfortunately, COVID-19 kind of put a damper on everything. And now we're trying to regroup to treat people, but still, what a great opportunity. You can cure hepatitis C with 8 weeks of tablets, if the patients take the tablets.
It's remarkable, even in my own lifetime, how it's changed. I'm sure you're a little bit older than me, so so you've seen all this change too. Were you around for the blood donation scandal when women were infected with Hep C because of the rhesus negative? Were you around for that?
No, I wasn't around for that, but I kind of saw the I kind of saw the history of it. So it was a few years before I arrived in Ireland, and I saw the court cases and the money that was given, and there was a whole bunch of centres kind of established, hepatology centres at the hospitals just to manage the blood transfusion or patients who were state infected with hepatitis C.
Mm-hmm. Yeah, no, it was one of those things. Look, I mean, it was awful at the time, but I suppose did that help our treatment of Hep C, because we had to put all hands on deck and develop these drugs and roll these out to the community? Do you think it had an effect on that, or no? Not really.
Not really. It didn't really. It's just actually what it did was, in some ways, is it was good to establish those centres, but it almost established a disconnect between those who didn't deserve to get hepatitis C and those who did deserve to get hepatitis C. Understand, the drug users, so the services were much better they were ring fenced for those who were state infected, but they weren't really ring fenced for other populations who developed hepatitis C.
Which isn't fair either.
Which isn't fair either. And then when the drugs came along for hepatitis C, if a drug user needed it clinically more than a state infected, the drugs probably disproportionately went to the state infected.
Okay.
Because the government really, had to, made special efforts to amend the mistakes that they'd made,
Yeah.
But it just kind of, it kind of showed you the inequality in healthcare, actually.
Which still exists today in very many areas, which we've just talked about.
And
most podcasts talking about that,
including long COVID. So which is a challenge.
Can I ask you a little bit? This is more of a personal question about how you manage the work-life balance and kids and work and social life and that, because you're obviously a very hard worker.
Yeah.
So how do you do it?
Well, I mean, I'm an old daddy, I would say. So I always. I guess I would have been a stay home dad, I think, and raise children, because that was always something I've interested in doing. I never did it because I was always the money earner. But my first family, I had 3 kids, and unfortunately my wife died, so I raised my kids myself. Okay. So that was just the reality of the situation. You do it, So I've always been, I guess, life meets you with challenges, and you have a choice. You either kind of roll over or kind of deal with them. So I've always kind of dealt with my challenges. So that was kind of the first challenge I had. But I've always been interested in sports. I've always been interested in activities. I don't see my job as just an 8 to 5. I went into medicine because I think it's absolutely exciting. I think it's so rewarding. Facing new challenges, some of the challenges I told you about, HIV was a challenge back in those days. Hepatitis C was a challenge. Lyme has been a challenge, continues to be a challenge. And then long COVID continues to be a challenge. So I kind of go at my job kind of as I like going to my job, you know, and I don't say it as 8 to 5, but also in terms of my, there's a lot of stress in the job, and the way I deal with my stress is when I go home, I'm a parent and I have the most fun at home. When I'm stressed at home, I go to the gym, you know, so I exercise, I play sports, I play squash, you know, so I kind of, you know, I find ways, I have found ways in my career to kind of try to, you know, balance my physical, mental health, you know, with job, with activities outside of the job. And I continue to do that.
It's worked even now, which is great. So I always ask my guest 2 questions, and the first one is, what advice would you give young people today?
Well, I guess the advice would be is that, you know, explore the world. You know, don't, you know, I lived in America for a number of years, and it's sort of like, you listen, 80% of Americans don't have a passport. You know, they just live in America. And I loved living in America for my time there, but Americans are the most isolated people. And there's so much value in leaving and exploring new cultures. And I, like I said, because of my job and my work in HIV and AIDS and working with people from all over the world, they invited me back. And I've gone to Brazil, I've gone throughout the Caribbean, I've gone all over the world, and I've had such a great, rich opportunity. You know, you go there and you give to people, but they give you so much more in return. So I think the advice to young people is go out there, explore, see the world, and do something to help the world, because you will get so much out of that opportunity. You know, you give something, but you get so much more in return. Doesn't matter if it's not a rich person. It's just you go to a village in rural, you know, kind of Eastern Cape, South Africa, and you know, you just meet somebody in the clinic, you know, a grandmother taking care of 7 grandchildren because the parents have died or gone. And you know what? Just that meeting with the grandmother and her talking to you, it's so inspirational to see how, you know, you have it so good.
Yeah.
They have it so difficult, but actually they're so rich in so many ways. So just exploring the world and you know, and meeting with people, interacting with people, helping people, you'll get so much more in return.
Okay. And finally, what is the meaning of life, in your opinion?
The meaning of life. Well, I guess I believe in religion, and I believe in, I believe in, you know, right and wrong. I'm a very black and white person. But you know, one of the things my mother used to always say, is she was a very kind person. She'd give things to people, and people would always be suspicious. Why are you doing this? You know, like as if people wanted something in return. My mother always would just say, pass it on. Pass on my kindness to somebody else. So I think the meaning of life is we're brought into life for a reason. I think we're brought into life to do good without expecting anything in return. And I think the meaning of life is that everything sorts itself out. I think you should live a good life, give to people, and just be happy in the gift of giving.
Thank you so much. This has been an absolute pleasure.
Yeah. Okay.
Thank you.